Welcome back, everybody. We're going to start on Chapter 10 now. Chapter 10 has a whole lot of information, and I don't want you to feel like it's too much information because this is what gets us into the realm of what makes us a radiologic technologist. This stuff is very important. I love that term, stuff. So let's explore why we make the adjustments that we make when we acquire images, and that is our exposure technique. Here are the objectives that are listed in your textbook. I know that I'm assuming the majority of you do these digitally. I don't know if someone actually has the book in hand. I'm not sure how that works, but I hope that you do actually read the entire chapter in detail and maybe make some notes so that you understand, because as you can see by these objectives, this is a lot of information. Now, I would like for you to read that entire chapter and then maybe listen to me again and then read it over a second time just so that you kind of pick up on some of the things that I talk about. So the main things today we will discuss are the relationships between MA and time, the effects of change of that on film screen and digital images. Yes, I know that we don't have film screen on an exam and it's not on your registry. However, when I show you how that changes on a film image and then compare it to digital, it'll make a little more sense to you. Then we're going to recognize how to correct exposure factors and then talk about KVP with production and exposures, and then talk about the factors that affect recorded detail, distortion, describe the use of grids, beam restriction, patient factors and how they affect the image receptor exposure, and then exposure factors that can affect exposure. I know that sounds like a lot of words. And then we're going to talk about how we modify those techniques for those patient factors that may come into play. And that can include body habitus, part thickness, and pediatric patients. And I'm sure you've covered all that in Intro to Patient Care. This chapter focuses on radiographic exposure techniques and the use of accessory devices. All of this and their effects on the radiation that reaches the image receptor and the image produced. As I go along, you may hear me use the word IR, that is an image receptor. So no matter what it is that you're working on, you can have film. There are still a few places that still have film. That's their image receptor. You can have CR, which is computed radiography, and then DR, which is direct radiography. So CR and DR are both a type of digital imaging, so just depending on what type of receptor that you have depends on which one that you're talking about. Radiographers have the responsibility of selecting the combination of exposure factors to produce a quality image. Knowledge of how these factors affect the image individually and in combination assists the radiographer to produce a radiographic image with the amount of information desired for diagnostic interpretation. And so we are here to get a quality image, and then how we change things to make sure that the image is appropriate. Because of the various types of IRs and how they respond differently to remnant, that exiting patient X-ray, these differences are noted throughout this chapter. However, regardless of the type of IR, the patient should never be exposed more than they have to be. So we should give them the least amount of radiation necessary to produce a diagnostic quality radiograph. We're going to discuss primary and secondary factors and the effects of that radiation reaching the IR. We're also going to learn some calculations, and this, even though I've been kind of hinting that you're going to need to do some math problems, this is something you will definitely have to know. You're going to have to talk about changes in MA and time, changes in the KV, changes in mass as it relates to source to image receptor distance, then the magnification factor, percent magnification, and then determining image and object size. Also, we're going to talk about how to calculate a change in mass when adding or removing a grid. Now, this last one is here and it's calculating the mass when we change film screen speed, we will not have to go over that one. So if you want to, you can put a big red X on there, okay? But it is in your book, so they were already listed when I took these for the PowerPoint. Just a quick review. Remember back to Chapter 6 when we discussed X-ray beam properties. Now, this is also part of what you need for this week in week 5. So when you're talking about beam properties, we discussed the importance of quantity and quality. And those two things are part of our primary factors we're going to discuss today. So just a review and a recap. Beam quantity refers to the total number of X-ray photons in a beam. The radiographer should always associate quantity with radiation dose. Dose, number of photons, quantity. All other factors remaining constant, an increase in quantity increases the dose delivered to the patient. Beam quantity is directly proportional to mass. And what is mass? We'll go into it in a minute, but it's milliamperage per second. Because mass controls the number of electrons that are boiling off the filament and available to produce X-rays, it's considered the primary factor controlling quantity. Double the mass, double the quantity. And if you have any adjustments that are needed, mass is the factor that you adjust for quantity. So quantity, mass, keep those two things in mind together. And then quality. Beam quality is the penetrating power of the X-ray beam. Penetration refers to those X-ray photons that are transmitted through the body and leave the body to reach the IR. It's desirable for some of the X-ray photons to penetrate the area of interest, or you wouldn't have any image at all. Photons that reach the image receptor create the dark shades of the image. Areas where no photons reach it are light or clear on the image. Both of them are needed to create the image and provide us contrast. So, what I didn't say over here, quantity has to do with density. Quality has to do with contrast. Beam quality is affected directly proportionally to KVP and filtration, but we're not going to talk about the filtration today. But it's controlled mainly by adjusting the KVP. As the KVP increases, the beam's ability to penetrate matter also increases, and vice versa. And we'll talk about those again as we move along. So like I said, this chapter is broken into primary and secondary factors. The primary exposure technique factors that the radiographer selects on the control panel are milliamperage, time of exposure, and kilovoltage peak. Depending on the type of control panel, milliamperage and time may be selected separately or combined as one factor, mass, which is milliamperage per second. Regardless, it's very important to understand how changing each one of these individually, or if you change all three of them, how it affects the radiation, how much exposes your patient and hits the IR and creates your image. Okay, so primary factors basically mass and KVP. So let's start with just the MA. MA is the quantity of radiation reaching the patient, and it affects the amount of remnant radiation that reaches the IR. The product of MA and time has a direct proportional relationship with the quantity of X-rays produced. So MA plus your time directly proportional to quantity. Once the anatomic part is adequately penetrated and the quantity of X-rays is increased, the exposure to the IR proportionally increases. Conversely, if the quantity is decreased, then the exposure decreases. Therefore, exposure to the IR can be decreased or increased by adjusting the amount of radiation, mass in general. Now, it is inversely related to the exposure time to maintain density. But this is a nice image right here. Less mass, less quantity, less getting to the receptor. more mass, more gets to the receptor. So that's what you need to know about MA in general, although we refer to it as mass more than anything. Now let's look at the exposure time. Time is directly proportional to radiation quantity, directly related to radiographic density, but it's inversely related to MA to maintain density, which put those two together, MA times time is mass. If you were to increase your MA to maintain density, you would decrease your time, and that's what we mean by inversely proportional. Mass together, MA and time, is directly responsible for the quantity of photons produced in the beam, therefore directly responsible for the brightness on a digital image. Time is the second part of mass, and this is responsible for the length of exposure. The longer the exposure, the more concentration of photons in one area, and that affects the brightness of the image. Because mass is the product of milliamperage and exposure time, increasing either one of them has the same effect of radiation exposure. Mass can be doubled by doubling MA or doubling the time. So if you only double one of them, you have doubled the entire mass. A change in either MA or time proportionally changes the mass. To maintain the same mass, you must increase MA and decrease the time. So it's hard for me to do that when you can't see my hands, but if you have mass, more mass is more exposure. But you can have an increase in MA but decrease your time and still have the same amount of mass and not change anything. And it's important for you as a radiographer to determine the amount of mass needed to produce an image. And it's not easy because there's a lot of variables at stake. And for example, just having a single phase generator produces less radiation than a high frequency generator. So when you have that, you may actually have to change your time to incorporate the MA. So when we say they are inversely related to maintain density, this is known as the reciprocity law, and you need to know this. The reciprocity law is the same as MA times time equals MAS, or mass. Any given combination of MA and time that is equal should produce the same number of photons. So it's either a short exposure or a long exposure, and you vary your MA to go along with that time. So if we want a short exposure because a patient cannot hold their breath, here's an example. So we need a short exposure time. So we're doing a chest x-ray. Patient cannot hold their breath. The original mass was 20. So if we have 20 mass, we know that 20 mass will produce an acceptable image. So any combination to get that 20 will give you the same amount of photons. That's what you need to know about the reciprocity law. So you can have 10 MA in 2 seconds, or you can have 100 MA at 0.2 seconds. If you multiply those two together, both of them will give you 20 mass. But which one would you pick if this example, I need a short exposure time? Well, your answer is that one because it has the least amount of time. You used more MA, but less time to get the exposure, so hopefully you were able to get it before the patient moved or held their breath better. So you need to know that we're going to always talk about mass from here on forward, but you need to know how to do this reciprocity. And I believe that you will have some problems in lab where you're given these. And so if you have a mass of X and then you got to change the time, how do you change them? Know that if one goes up, the other goes down, but you always have to have the same amount of mass. Now, we also talked about some variables, and variables that we need to consider. I want you to know right now that it's the age of your patient, the condition of the patient, and the pathology of the patient. Now, all of these are variables that you need to consider when you decide what mask to use. We're going to talk about the variables in general later, but I just wanted to give you an example. So let's pretend, and isn't this a lovely family? If anybody doesn't know who this family is, Google it because it's real quick. So we have dad, mom, son, daughter, little daughter, and grandpa. Say we were doing everybody's chest x-ray. Now, number one, these two may be the same, except that a man who's bigger than a woman, and they're usually more barrel-chested, and a woman's going to have breasts in the way. So both of those different types of body types will make a difference. Now, and here I'm just going to have to throw it out there because I have to. So with Homer, if we do Homer and compare him to his son Bart, look how much smaller Bart is. And he's a child, so he's in a growing stage, so you definitely want to decrease your mass because you want to decrease the exposure to them. Now, Bart and this sister may be about the same, but the little sister is going to need even less because she's smaller. And then look at Grandpa. Yes, he may be the same size as Homer, but the difference is his bones are more frail and he may have some kind of respiratory issue going on just because of his age, and that would be pathology. So age, the condition, man versus woman versus baby, and then their pathology. Again, we'll talk about all those later, but I want you to know that that also makes a difference in what mask that you actually choose. With variables, you also need to know that for any given mass, an image receptor also responds differently. And that's what I was talking about. Now I'm going to talk about how mass changes with image receptors before we go any further. So with image receptors, for example, mass does not control the amount of brightness that's displayed within a digital image. So right here, I'm talking about digital. A digital IR can detect a wider range of radiation intensities. Now, have we talked about that yet? No. But it's something called dynamic range. So being able to take a wider dynamic range that exits the patient, therefore a digital IR is not as dependent on the mass as a film screen IR is, which right there tells you if you have a digital IR, you should automatically know or be able to use less mass than when we had film. Say we because I used film for the first 20 years of my career. However, exposure errors can adversely affect the quality of a digital image. If your MA is too low, which means you've got too little MA or mass, then you're going to have the possibility of image brightness is adjusted during computer processing to achieve the desired level. But even though the brightness has been adjusted, there may be increased quantum noise. We'll get to that a little bit later too. If your mass is too high, again, the brightness can be adjusted. So when we get to a digital image, when we start talking about the quality of that image, we're going to see how nice that it looks to your eye. Whether it's bright, it's dark, it's light, all of these different words. Well, with an image receptor, mass controls the density, which in digital refers to brightness. So if your mass is too high, you can actually adjust it on the computer, but you have overexposed your patient, and that's not good. This is all for digital IRs, okay? So the radiographer should be diligent in monitoring exposure indicators and ensure that the quality images are obtained using the least amount of radiation possible to get that image. Now, whether you read it electronically or in your hands, I would like for you to look at box 10-1 in chapter 10, and it talks about radiation protection with excessive exposures. Okay, that kind of relates to your assignment for this week and talking about dose creep and how that has happened over the years. But let's move on. This is a digital IR. You can fix just about any type of image that you have, but you may have quantum noise, you may have overexposure. The reason I want to throw in film screen is because with a film, the mass controls the density produced in the image. Now I'm sure, and both classes of you have these in your lab. This is a view box, and this is a piece of film where someone took a skull x-ray. Now, when we had to produce this film, the reason it's important to still throw it in there, not that you're going to have to take one, you might, but is that we can see density. On this skull x-ray, the exposure used to make that x-ray is the exposure that you used. So if you had made it with too much mass, the density is increased, and when the mass is decreased, the density is decreased. If your film is too light, not enough density, then you have to increase your mass to make it better. But guess what? You don't have a digital computer to fix that image. You got to go take another x-ray. If for some reason you use too much mass, then you have an overexposed film. You cannot fix it on film. So when I am in the lab and I'm showing someone the differences, I want you to still imagine you can hold this piece of film in your hand and see the differences with them, okay? So the relationship between radiation exposure, intensity, and density will cover in more detail in another chapter. But with film, again, you will not be asked about these things as far as the film itself goes. But when it comes to mass, if you were using film, the film speed and then the grid and the cassette, all of that also makes a difference. Now, when it's unacceptable, then the density is outside of the acceptable range, you're going to have to repeat it. And so you need to know how much of a change in mass is needed to correct for the density error. So even when we get into the digital part, which is all that you will be working with, you need to understand why it's important to pick the right mass to begin with. So, I know film's no longer studied, and it will not be on your registry, but look at these reasons for why we're doing it. Okay, with a film, you either get it right or you don't. And when you don't, you had to take another image, and that's unnecessary exposure. So this first image is considered optimal. This is a pretend film, okay? Now, I also want you to understand this is not a real person, so nobody did these experiments on a real person. This is a fake skeleton, but this is an original image. And it's great. So that's a hip. That's a hip x-ray. You're going to learn how to do those soon. Now, this one was taken and it's decreased density. Now, if you had this in the digital world, you could actually adjust your, I just say knobs, there's no other way to say it, but you can actually adjust the brightness level or the density level, but it's called brightness, and you could fix it. But if that were a film, you could not. So you would have had to take the exposure again. But you need to know how much you need to change it. This is the third one, and this is a hip, and it is overexposed. So this is an increase when the density is doubled. The middle one, I'm sorry, is the density was halved. So they did half the mass. So optimal, half the mass, doubled the mass. And again, if you took this of the hip, honestly, some radiologists may say, no, I don't need another one, because with a film, they could have put it on something called a hot light. Ask your lab instructor about those. But with digital, you can actually take this image and fix it or correct it on the view on your screen. So it does make a difference, and that's why it's worth talking about film exposures. So in general, for repeat radiographs necessitated by density errors, those are your number one reasons to repeat a film. The mass is adjusted by a factor of 2. Okay, so the minimum change is either to double your mass or half your mass. This typically brings the optical densities back within the straight line portion of the film sensitometric curve, but now that's for film, but that is also for digital. So if you take an exposure, we'll talk about it later, I'm not trying to confuse you, but you'll get something called a number. So the computer says, yes, you were within this range or you were not within this range. And by knowing that, you need to know if you need to go up or down in your mass. And as mentioned before, it may take more than doubling to correct for a density error. If it necessitates an adjustment greater than 2, then you should at least go on up possibly by a factor of 4. So knowing that if doubling the mass didn't work, well then you're going to have to double it again. Radiographs that have sufficient but not optimal density are usually not repeated. Okay, you know, it's not the greatest, but it'll work. And if that's true, it's because you don't want to expose your patient again. If a radiograph must be repeated because of a positioning error, then that's when you may want to make an adjustment in density to get that optimal quality. But to make a visible change, this is very, very important, any visible change in radiographic density requires that the minimum amount of change is 30%. So you need to know that. That's going to be a test question. I don't know if just on this chest, you will see that on your registry. But to make a visible change in radiographic density, you have to change mass by at least 30%. Now there's also a range given between 25 and 35, but they usually say 30%. But radiographic images are not usually repeated only to make a visible change. When you repeat something, it's because of insufficient or excessive, so you need to either double or half it. To best visualize the anatomic area of interest, the mass selected must produce a sufficient amount of radiation reaching the IR, regardless of the type. Doesn't matter if it's film, CR, or DR. Excessive or insufficient mass also affects quality and the patient's dose, so you have to worry about that. Now let's look at some film errors. These errors had to be repeated. Didn't matter, but look at the first one. Now that's supposed to be a hip also. So if you adjust for mass for density errors, a greater increase in mass, double that mass would not make it enough. So you're going to have to go at least 4 times. And that's what you need to realize. When you could see this on a film, you knew exactly what you needed to change. So that right there is so low, you would just automatically know you need to at least go by that factor of 4. And then this one, if you had that image, you didn't just somewhat overexpose, you way overexposed. You need to go at least 1/4 of what you originally used. So here we'll take it this way. If this was 20 mass and it wasn't enough, you're going to have to go by to 80. If this was 20 mass, you're going to have to go all the way down to 5. So you go by the 4th. So just think about it that way, and that's what it takes when you see a repeat. But that would be a film, because if you did this with digital, because of that wide dynamic range, the image brightness does not solely depend on mass or KVP. Image contrast does not solely depend on KVP. But you must understand how they affect the image and not rely on the computer system to correct your mistake. So I said earlier, digital imaging does have a wide dynamic range. Brightness is your mass, contrast is your KVP. But in the event of too much mass or KVP, computer processing adjusts that brightness and contrast for you, but the patient can be overexposed. If you by chance have too little, the computer will still adjust it, but then you get something called quantum noise. and we'll talk about that for just a second. Even though we've not gone over all of these terms, it's important to know what quantum noise is, and it's exactly what you would think. So, noise is bad for your image. So when I compared the film images for you, I wasn't demonstrating that you could have noise or not. Those were films that we saw earlier, but this is an exam of a knee done on a digital machine, and it was too little technique. The computer adjusted it, and that would be an acceptable radiograph or not. I mean, it's kind of bad, but depending on the patient, you may not get a chance to take another one. But now you have, I don't know any other way to say it, it's a crappy image, because look at all this. That's exactly the noise that I was talking about. But with digital processing, sometimes you can make a poor image acceptable, and that may not require another exposure. If that were a film, it's going to look more like, here I'm going to go to this one, it probably looked more like this, and you had to take it over. You can't create something that's not there already. So this is what quantum noise looks like. So when you hear me say that later, that is what you're trying to avoid by having the right technique the first time. So let's look at a couple of more images right here. Now, this is, when I showed you the different techniques on the film, did you notice there was a light one, there was an optimal one, and there was a dark one? Well, this is a digital skull. And looky, this one was taken at 4 mass, 32 mass, 200 mass, and 400 mass. And guess what? They all look good. Soak that in just a little bit. This is a lateral skull. If you look at the mass for each of them, you can tell barely a little difference in the images. But if you look closely at this one, and that means I don't know how close you have to get to your screen, it may be a little darker. Actually, I can probably see it more right in here in this part of the skull. But that's totally an acceptable image. Now, it's darker, but it's all acceptable, but so was this one. So at 4 mass, and I don't even see any quantum noise right here. You know, so obviously 4 mass was enough, which is unusual because a skull typically takes about 32. But if that was acceptable, why would you use 400 mass? Well, you shouldn't, because you just overexposed the patient. And that is the problem with digital imaging today. You need to know what the mass is to get the acceptable image and not do one, well, let's just make sure. That is unacceptable to use this type of technique for a skull x-ray, okay? So you have to be real careful so it doesn't happen again. Now, let's look at one more. When you compare the modalities, these are film, range of exposures on analog film. Now, it really isn't, because if you look closely you can see little pixels in here. But if you had film, underexposed, good, overexposed, and extremely overexposed. But with digital, well, guess what? They all look the same. And that means it was kind of like the skull we just had. They look similar, but this one being underexposed, here you can see the quantum noise a little bit better, but on here you don't, and this one may look better, but it's extremely overexposed. So when you compare the two, it's always good to look at that. And if your image is too light, you must increase by at least 30% to make a difference. But sometimes it takes doubling the mass to really make a difference. And those are two important things. Okay. First primary factor out of the way, mass. Let's move on. I promise once I get through a little bit more, all of this will make a little bit more sense, okay? And in case you didn't know, that's a gremlin right there. Isn't he really cute? Okay, let's move along. Kilovoltage. This is our second primary factor. I guess third if you want to say MA time and then kVp. I think of them as two things, mass, kVp. The kVp affects the exposure to the image receptor because it alters the amount and penetrating ability of the X-ray beam. If you remember back, KVP does affect the quantity, but not to the extent that mass does. It's more about the penetrating ability. The area of interest must be adequately penetrated before the mass can be adjusted to produce a quality image. When adequate penetration is achieved, further increasing the KV results in more radiation reaching the IR. Unlike mass, the KVP affects the amount of radiation exposure to the IR and the amount of radiation to your patient and radiographic contrast. So here are your different energies. This is a low energy, low KVP. And so there's not a lot of those. And it's kind of taking its time, la-di-da-di-da. But this high energy beam means more reach down here. Photons have more energy to penetrate the part. Now, this is important because you need to have enough energy to reach the IR, but you also need a quality radiograph. So let's go and compare this a little bit. With the image receptors, go back to your digital. So this is a digital, and this one is actually a DR. And you can tell by this little cord right here. So adequate penetration of the anatomic area of interest is equally important when using digital, and therefore KVP selection is important in producing a quality image. Assuming the part is adequately penetrated, changing the KV does not affect the digital image the same way as a film screen. However, image brightness and contrast, those two words again, are primarily controlled during computer processing. So, when the KVP that's too low is selected, the computer can adjust it, but you're going to have that quantum noise again. If your KVP is too high, the brightness and contrast are adjusted, but you just increase the exposure to your patient. And if you have too much KV, when it gets through, more of it reached your film, then you can have increased scatter, which reaches the IR and it adversely affects the image quality. And that's because it degrades our contrast. All of these terms will start coming together before the end of this quarter, and they will make more sense, I promise. But for right now, keep in mind KVP contrast. So, the KVP has a greater effect on the image when using film screen. That's why I'm throwing you in a film screen again. Increasing the KVP increases IR exposure and the density produced on a film image, and decreasing it decreases exposure and the density produced on a film. But even more important is the contrast. So this is another nice little film stuck on a view box, and this is of a knee, and look, they've got two little screws in here. And what's important here is that not only am I seeing the bone, I'm seeing some of the tissue around that bone. And that's something you'll learn also once we get into positioning, that we're not just about taking x-rays of the bone, we want to see the entire part that we just x-rayed. So, for film screen IRs, KVP has a direct relationship with density. However, the effect of density is not equal throughout the range, and a greater change in the KVP is needed when operating at high KVP. And that high KVP is anything over than 90. And when you talk about low KVP, you're talking about less than 70. So let's look at this image right here. Now that is a hip x-ray. So this is a 50 KVP. What do you notice about this? And it's hard because I don't have you in front of me to say, oh, it looks. What I want you to see right there is that this has high contrast. So high contrast comes from low KVP. And when I say high contrast, that means this is white and that's black. Now, this is the same image at 90 kV. Now, I can still see the bones as well, but notice how it's more gray throughout the whole thing. So we can change the KVP and just adjust the mass so that you still get a decent image, but it depends on what your radiologist prefers when they read these films. Do they like contrasty or gray? Now, here is a 10 kVp increase, okay? So we increase by 10 kVp. You ready? This is the 50 kVp, but we had the mass to go along with it. So we upped it by 10 kV. Uh-oh, it's too dark. Here, we upped it 10 kV from the 90, and look at that. That's not so bad. So this affected the density more in the low kVp range than this one did. And honestly, this is actually a pretty good image. But I also want you to cross-check, look at this one, and then look at this one. If this were a real patient, seeing all these little lines in the bone are actually very important. So this is your best image right here out of all four of them. But even here, it's too dark. This one may be just a little too gray and dark. Okay, so this is, again, film screen and the differences of adjusting your kVp. But if you go back to some of those others, we left the kVp the same, then you can have four images that all look the same because your computer will fix it. Because kVp affects the amount of radiation reaching the IR, the effect on digital is similar to the effect of mass. Similar. If there's too much radiation reaching the IR, then you get a digital image with the appropriate level of brightness as a result of computer adjustment. However, your patient has been overexposed. If you have too little, the computer can be adjusted for the level of brightness, but the increased noise decreases the quality of the image. So both of those are very important, and you need to know that. So patient is overexposed and you have an increased noise, reducing the quality of the image. Both of those things are important so that you know to use the right technique the first time. Now, let's go on. Kilovoltage is not a factor typically manipulated to vary the amount of exposure in film screen imaging. It's also not for digital because kV also affects contrast. However, sometimes it's necessary to manipulate the kV to maintain required exposure to the IR. Example, if you use a portable or mobile X-ray equipment, then it may limit the choice of mass settings. You may not have as much. So then you have to use the kVp. So by doing that, you need to know of something called the 15% rule. Maintaining or adjusting exposure to the IR can be accomplished with the 15% rule, and that is changing the kV by 15% is the same as double or half the mass. Here's an example. If you increase the kV from 82 to 94, and if you did your math, that's 15%, it's the same as increasing your mass from 10 to 20, doubling it. Now, when you do this, you leave your mass alone, or you double your mass, then you need to decrease your kV so that you get the same image. So decreasing it by 15% decreases the exposure unless the mass is increased. Sometimes making one of these adjustments is necessary depending on the body part and a couple of other things. When we talk about the penetrating power of the kVp, it's all about the contrast. And I did this so that you know it's black and white. How contrasty is it? It's not grayed. So altering the penetrating power of the X-ray beam affects its absorption in the body and transmission through the body so that it hits the IR. Higher kV increases penetrating and results in less absorption, more transmission, which results in less variation in intensities. As a result, high kVp exams have lower contrast. When low kVp is used, the X-ray beam penetration is decreased, resulting in more absorption, less transmission, so there's more variation in the exiting beam. This produces a higher contrast. Low kV, higher contrast. These are some rules that you need to get into your head and memorize it because you'll be asked it over and over again. Here's an example. Now these are hands. Of course you know that. But this is a high KVP, low contrast. See how it's all kind of grayed out? But if we were doing this for soft tissue, this is very important because now I can see the skin around this entire hand. So that's important. But typically you do it for bone, and here it's a lower KV, high contrast, very black and white. Now I can see these bones a little bit better. This would be good also if you were thinking of a bone cyst or a bone fracture, and it just doesn't really matter. And notice here in the carpal area, these bones kind of metal all together, whereas these you can see distinctly apart from one another. Now, that's also the tips of the fingers are burned out just a little bit, but you could adjust that if that was computerized. So that's just an example of your different contrasts. Here's the example out of your book. So the one on the left is a higher KV, and that's what you typically use for a chest x-ray. Because higher KVP increases the penetrating power, less is absorbed, more is transmitted. So there's less variation that comes out on your IR. And you want that for a chest x-ray because with that you can now see the lungs and some of the bone. Okay, so this is important. Bone, fat, and air travels differently through there. Now with your lower KV, what goes through the bone part, guess what? Not much of it comes out. And that's why this is very dark. So your air, there's going to be more of it that transmits, and your air-filled lung is going to be darker than it should be. So lower KV decreases the penetration, resulting in more absorption, less transmission, greater variation. See, this is kind of grayed. You want that in a chest x-ray. You don't want that necessarily in a hand, but in this chest, this is the one that you want. And this is a nice example of how it actually looks. So when we talk about variables, changing the KVP affects its absorption, I've already said the word, and transmission as it interacts with anatomic tissue. However, using a higher KVP reduces the total number of interactions and increases the amount of X-rays transmitted. So remember that word Compton scattering? In these interactions, more Compton scattering than X-ray absorption occurs. So Compton scattering occurs more with higher KV because it goes through the body, reaches your IR. Photoelectric absorption happens with lower KV because more of it stays in the body. Now, it also has to do with anatomic tissues, how they're actually absorbing or transmitting, and it has to do with the structures that are visualized, and it can do with the preference of the person who is interpreting. So for most anatomic regions, there is an accepted range of KVP that gives appropriate levels of contrast. And you're going to find that when you get to go to clinical, they're going to say for a chest x-ray we use this range of KVP. For a foot x-ray we use this, because they've already got it set for their equipment and they know how it works. And as long as you have the KVP selected, then it can be further manipulated later to making an image that's acceptable. So, repeats. Radiographs are generally not repeated because of contrast errors. So this is all about KVP. More often, the radiographer evaluates the level of contrast achieved to improve the contrast for additional radiographs. Meaning, if you saw that it was not exactly where you wanted it to be, you're not going to take it again because your computer can fix it, but you will change it if you have to do another one or on another patient. And then if a repeat is necessary and KVP is to be adjusted, you're going to use the 15% rule. And that either increases or decreases your contrast. In addition, whenever a 15% change is made to the KVP, you really should adjust by a factor of 2 for the mass also. And remember, a 15% change in kV does not produce the same effect across the entire range. A greater increase is needed for high kV, which is 90 and above, than it is for low kV, below 70. The selection of kVp alters its absorption and transmission through the anatomic part regardless of the type of IR. However, we prefer the digital technique because exposures using higher kV with lower mass are recommended in digital because the contrast is controlled during processing. Higher kV and lower mass values are not recommended as a general rule during film screen because of the contrast. It's required to best visualize the structures. This is straight out of your book, and I apologize, it's hard to take a picture of something in a book and it's kind of warped on the side. But this is a box that's in Chapter 10 that you need to know about with kVp and mass, because everything that we learn does specifically go to your radiation protection later on. Whenever possible, a higher kV, lower mass should be used. And then the same thing. For example, changing from 70 to 81 in a pelvis is 15%, and it requires half the mass needed at 70. Higher kV increases beam penetration, therefore less quantity of radiation is needed. By doing this in this range, then you have actually decreased the exposure to your patient, but you've gotten a better image. So, hold that thought. For now, we've covered the portion of Chapter 10 that relates to Week 5. I am going to continue later, and I'll put it in a separate recording so that you have the rest of Chapter 10 for next week. But for right now, I want you to think about what we have covered. We covered these objectives: the relationship between MA and time, the changes in MA and time with film screen and digital, and how to correct exposure factors for density, and how kVp affects radiation production and image receptor exposure. We also talked about how to calculate a change in MA and time to maintain an exposure. Practice that reciprocity law. There are some examples in your book, and there's some examples in the I put it on an announcement or in a message to you about a math book that's available. You need to work on those. And then also the calculation changes in the kVp. So your MA and time is called the reciprocity law. You'll need to know what that is, how to make a change, and then the 15% rule for kVp. You need to practice these, and you need to be able to perform some in the lab because you're going to have to do that. So until next week, think about this lovely radiograph and think about what you're going to do between now and then. I want to make sure that you get all of your assignments taken care of, and I can't wait to go over secondary factors because you're going to learn some more. Thanks.